Hello, friends, colleagues, and fellows. Chad Golly here. I'm going to introduce a case study regarding a patient with complaints of lower back and lower leg pain, and hopefully this will go better than the last time. A 55-year-old female presents to the pain clinic complaining of lower back and leg pain, left greater than the right. Her MRI was completed 2 weeks ago and states that it feels like a knife is sticking into her back and left leg. She currently lives on a third-floor apartment, and while climbing the steps and doing light housework, her symptoms are more severe in nature. She has had this pain for 4 years. Her back pain is worse in the morning, while the leg pain is worse in the afternoon and evening hours. She describes her back pain as a sharp shooting pain that travels from her lower back to her left foot. Her right knee aches constantly and reports electrical stimuli to the right thigh. Physical findings that she reports includes numbness and tingling to the left leg and plantar surface of foot and weakness of her left leg. This is intensified with activity, prolonged positions, stress, standing, walking, and lifting things with any weight. Her symptoms are relieved with stretching exercises, heating pad, and rest. Her medication history includes Plavix, oxycodone, cyclobenzaprine, tramadol, buspirone, Zyprexa, Zoloft, and Seroquel. Her cardiologist informed her that she will need a complete stress test before any sort of treatment plan can be prepared. Her past medical history is remarkable for CVA, CHF, hypertension, heart stents a year ago, chronic kidney disease, breast cancer, anxiety, and depression. She had a total knee and has had pain in that knee ever since. She has been doing physical therapy and aquatic therapy, which has been effective. Her social history consists of being a divorced mother of three and lives with her significant other. She has a 10th grade education and is currently not working because of her disability. She smokes one pack a day and uses marijuana occasionally, and she does not drink alcohol. Upon examination, the patient is somewhat overweight and is noted to have an antalgic gait, walks with a cane favoring her right knee. Her right lower extremity has decreased range of motion as well as pain with range of motion and weight bearing. Left lower extremity has normal range of motion and strength. All other systems are unremarkable. Her focused physical exam showed that when compressed, she had SI joint pain on the left, negative on the right, greater trochanteric pain on the left, negative on the right, and her paraspinal muscles were painful when compressed on the left, negative on the right. For her pain generator test, she was negative for bilateral straight leg raises. Patrick's test was positive on the left side only. Internal hip rotation was negative bilaterally. She was positive for bilateral facet loading, extension, and flexion. Lateral flexion were both negative bilaterally. There was no vertebral tenderness or pelvic asymmetry. Lumbar extension was only 5 degrees with normal flexion. Lateral flexion was normal on the right and only 30 degrees on the left. It was noted that there was diminished sensation to pinprick to L5-S1 on the left. The MRI shows that there are bilateral facet effusions and degenerative changes at L4-5, with extensive facet hypertrophy on the right. There are diffuse, broad-based disc protrusions with lateral components at L4-5, where the disc is adjacent to the exiting nerve root. At L5-S1, facet hypertrophy is noted. Behind the L4 level, there is either a 4 mm arachnoid cyst or possibly facet hypertrophy. At L2-3, it shows bilateral facet effusions and degenerative changes. There are several different treatment options that this patient could benefit from, based on her symptoms of lower back pain and leg pain. The first treatment I would do would be a bilateral L4-5 transforaminal epidural, assuming all anticoagulants have been stopped. This injection will hopefully help with her knife stabbing pain in her left leg and the pain she's had in her right knee. After proper needle placement and verification with contrast dye, I would inject a mixture of 2 cc's of 5% bupivacaine 2 cc's of saline, and 2 cc's of Decadron, using half on each side. Plan B would be to do a bilateral L2 through 5 medial branch block. She stated earlier that her low back pain is worse in the morning and has had positive bilateral facet loading. Treatment A may help with some of her low back pain, but if not, hopefully this diagnostic treatment will help so she can proceed to RFA. As previously stated, there are several injections that can be done for this patient. I will also add that if treatment A and B did not help with some of her gluteal and hip pain, I would suggest trying a left-sided SI joint or left-sided GTB injection later down the road, as her compression tests were positive for these. In conclusion, it will be important to provide not only this patient but all of our patients with adequate information and expectations. While these particular procedures will hopefully decrease her pain level so she can perform daily activities, it should be explained that this will most likely not cure her in the long run. It should be explained to her that there are steps that she can do to further aid in her treatment. Providing information regarding the benefits of smoking cessation and daily exercises such as walking or yoga is probably more crucial than the injection itself. Lifestyle changes are key. If all of the above has been done and the patient still complains of pain, then the S word should be discussed. For some, surgery may be the only fix and is something that the patient and the pain practitioner must be prepared for. With that, I will conclude this final Pecha Kucha and thank you for your time. Hit 'em with the hive.